Okay, hi everybody. Welcome. It is 1 o'clock, so we're going to go ahead and get started. I see a number of people are still joining the meeting, so we'll, as we're getting going here, like we've always been doing, just a reminder that we're recording these meetings just so everyone is aware. Elise, just quickly, I'm going to keep you as the host of this so that you could admit people as they're coming in. So we're recording these meetings, though they're available on the website for planforchildren.org as recordings, as are the meeting minutes afterwards and other materials. As we're getting going here, if you wouldn't mind entering in your name and organization into the chat box by way of introduction, that would be great. And I think that brings us to sharing the agenda, which actually, yep, there we go. Thank you, Elise. So today we are gonna I won't revisit the goals. I think everybody's pretty familiar with the goals at this point around 2 models of care, as well as core components of a crisis continuum in other contexts. We are nearing the end of our defined term of meetings. So we're in December now. It's hard to believe we started this all the way back in June, but here we are. So we are wrapping things up pretty soon, and we can talk about next steps at the end of the agenda. The main material for today was the crisis stabilization unit model parameters. So we're going to talk about that today, as well as finalizing our work group recommendations. I have a slide to share with you on that, where we can take a look at some draft recommendations and get your feedback and input on that. And we have a healthy amount of time towards the end just to finalize some things, identify next steps, and then wrap up. So with that, I will introduce my co-facilitator in this process, Tim Marshall.
Good afternoon, everyone. Thank you all again for joining us and what is hopefully our last meeting. And again, we'll figure out not to continue the discussion about models, but to talk about opportunities to kind of continue to check in on progress on not just activities related to this work group, but all the work groups. So we have the 3 work groups. We had the short term as a 4th group, but there has been across multiple groups a desire to continue to meet on some cadence yet to be determined, to continue to follow up any activities or recommendations that are being put forth by this work group and or others. So as the primary area of focus for this group was to put forth a Connecticut-based model for a behavioral health urgent care and a crisis stabilization unit. Again, those have many different titles in different areas. So that is the scope of this work group. It's what we set out to do, and we'll continue to finalize that recommendations. I know that there's a lot of additional suggestions or recommendations above and beyond those, and we have been working on recommendations that will put all the recommendations in context, including what other suggested recommendations need to accompany any recommendation for behavioral health urgent care or a crisis stabilization unit. And we talked about that these 2 new levels of care or models of practice, if you will not be successful unless there's not a series of accompanying recommendations that also move forward at the same time. So those pieces have been discussed and will continue to be. But we did have the specific goal of putting forth a model of practice to be considered for Connecticut for these 2 levels of care. So again, thank you all for joining, and back to you, Jeff.
Okay, great. Thanks, Tim. And Elise, if you have the CSU model, we can put that up. And just to introduce this agenda item, we did, hopefully you all received, we distributed this a couple of different ways. One was by way of email attachment a week ago, so that folks had a chance to take a look at it. We invited people to send us back either written track changes or comments on a Word version that was emailed out. And we also made a Google Doc of this report available on a share drive. And we did not receive any feedback in the last week. So if you did send it, we didn't receive it. We did not get any other feedback. A little bit of written or emailed feedback on the model within the last couple of days, but substantively not much feedback on the model. So I'm expecting that we're going to have a robust conversation today, because I do not take that as an indication that nobody has any thoughts or suggestions or modifications. So rather than going through section by section, I think what has worked well in the past is just opening up the floor for people to make some introductory remarks about their overall general impressions about the description or specific sections that they think require some attention. So with that, I'll open up the floor. And if you wouldn't mind actually raising your hand, we'll keep an eye on the chat and call out people in order and make sure we have give everybody a chance to offer their feedback. Yeah, and Jason, I see your note that Google Docs is blocked at Yale New Haven Health. Yeah, that's why we send it out 2 different ways, including as an email Word document attachment. Jason, go ahead.
Thanks. And yeah, thanks for sending it out multiple ways. I tried to get on the docs, and most of our internet here is blocked these days. So I don't know if others feel the pain of that sometimes. But in general, since we're kind of moving on to this crisis stabilization unit, I think we may have made it apparent, but just to make it more apparent, is that Yale New Haven Health, more so than just the Children's Hospital, we really do not believe that this is the right place to put multi-millions of dollars of money. I think that, looking at how this is designed, there's a lot of work that's been put into it, and it really looks like it's been thought through. But in the end, it does resemble a mix between an already inpatient, an unlocked inpatient, and an SFIT. And the SFITs, we're told, aren't used, even though we have kids waiting in the ED to go to them. And inpatient, we don't believe is the answer. Having hundreds of inpatient beds here, we really want to see the money used to, urgent cares. I think we can absolutely can get on board. But the crisis stabilization, I think looking at ways to get kids out of the inpatient units into their homes or into, actual day-to-day partial hospital programs, things like that, is a much better use of the kind of money that this would involve. Supporting buildings and staffing 24/7 is so much more expensive than really supporting an outpatient program, where I think that these types of patients can be much more successful. And a lot of the pieces in the CSU goals are really how we run our inpatient units. Up to 14 days. We try not to even keep them that long. And minus the being unlocked, it just so clearly and closely represents the mix between an SFIT and an inpatient. And I personally, and we don't see that being completely successful for the issues that we're dealing with.
So Jason, a couple of comments here. So I just want to be sure. So the process was pretty clearly articulated from the beginning, that we were talking about developing 2 specific levels of care to put forward. So you're objecting to that you participate, or that we put forward the second level of care. So you participated in the group, and you're objecting to putting forward a subacute level of care in Connecticut. That's what you're saying right now?
Yes. Yeah. I think that developing the outpatient model is going to be much more successful than developing a subacute model.
Okay. So that part, this group is not making recommendations about which items will be funded or not funded. I think we have been talking about from the beginning that there are recommendations, or there's a whole bunch of recommendations coming forward in a variety of settings. This group made a bunch of them in the short term recommendations, and somebody's job is going to be doing that. And that was discussed a little bit yesterday in the Children's Behavioral Health Plan Implementation Advisory Board on what the process is. And that's really an executive branch and legislative branch conversation, that there are some forms that have already put forward. There will be some additional forms coming up. So the actual funding pieces and decisions being made. So we set out to develop 2 levels of care. And so you can certainly go ahead and suggest that the goal for the second part of this group was not what you think is a worthwhile to fund at this time, but that we did make it pretty clear that we were developing a recommendation for a subacute. Now, whether the subacute crisis stabilization unit gets funded or not is a decision to be determined. But right this second, that is not, that we were just making the recommendations for this model of implementation.
Let me just add one more thing and then I'll turn it over to Frank. One thing is that in the CSU report, what we did in the behavioral health urgent care that we did not put into the CSU report that we will put in is that sort of section on broader system context. So that needs to be added here as well, because I think it's been clearly stated in this work group numerous times that none of these models or levels of care will work without attention to other parts of the system. And secondly, I would just add that by proposing a crisis stabilization unit, it does not preclude enhanced investments in other parts of the system. Both can be done. Frank?
So with all due respect, Jeff, I wonder about that. Is that actually possible for both to be done? The pie is not limitless. There's a limited amount of funding. And so I really question that. I question whether the juice is worth the squeeze, as they say, in terms of creating these additional, this additional setting. And Tim, maybe I missed it, but in the beginning, I was aware that we were talking about behavioral health urgent access centers. And in one of the first, like the second meeting or so when this was raised, I remember asking about this. Why are we doing this? It sounds like it sounds basically like an inpatient bed. I know I asked that question and was told that, this was part of the plan. And I thought, oh, gee, I must have missed it, some part of the initial announcements. It was urgent access, not crisis stabilization, as my memory was. The crisis stabilization came into it when we were raising, well, what do we do at 23 hours? And how do we manage kids who are there in the behavioral health urgent access program past 23 hours? But that's just my recollection. I know I'm the only provider here who actually treated kids for at least 10 years in an inpatient psychiatric unit. Other than the locked part of this, I can't understand what's different, and I don't understand how we will identify.
Well, there's a difference of opinion here because a community-based, non-hospital-based, subacute, unlocked facility is very different than an inpatient hospital level of care. And at Yale New Haven is free to express the decision that we went forward with a Connecticut recommendation for a subacute model. I think we made clear from the beginning that there were two levels of care that we were going to be focusing on in this work group. And if you missed that, there was a second level of care there. Our apologies to that, but there is, by both level of care definition and approval process, a very big difference between an acute and a subacute. There is some similarities. I would definitely grant you that. And if Yale New Haven wants to object to making a second subacute in Connecticut, in addition to the PRTF, and you may recall, I think there was recommendations to strengthen the PRTF subacute model of practice. So there were two pieces of that piece. So we were, in fact, as recent as yesterday, consulting with other states, and we had a conversation with both New York, Massachusetts, and Georgia, specifically around this point. And they all have these subacute beds as separate and unique and different than. And we talked specifically around levels of care and referrals. And again, referrals in and referrals to higher levels of care may have similar processes, but they're definitely different levels of care. So again, I think the purpose here is not to debate whether or not Connecticut should build or not build. I think the debate, we set out a goal for this work group to put forth, if we were to put forth a model in Connecticut, what would it be? And so that's what we're doing. Again, I know people want to talk about investments and who's prioritizing and who will be doing that. That's beyond this work group's purview. And there have been a lot of conversations in different avenues about where that will happen. But I also will say that there's been lots of communication during this meeting and sometimes afterwards, and there's not agreement always on all the conversations we have had. And so we, as the facilitators and the authors of this, have tried to be fully transparent about walking the best line forward from as much of the consensus of this group as possible. But I do think we made it very clear from the beginning that our goal was to develop a model of practice for Connecticut for 2 different levels of care, the 23-hour alternative to the ED and the subacute setting. So again, apologies if we didn't, if that was less than clear to some people.
Tim, this is Anne. Maybe it would help to have a little bit better idea of what kind of kids we're talking about going to this, this type of facility. I mean, we're talking about a crisis stabilization unit. Is this a child in crisis or a family in crisis that just can't take the kid home from an ED or from another center?
We can scroll down to the target population if you like.
Yeah,
again,
no,
I think you want to,
to.
you can again raise some points to what we have been talking about here. And I think probably the best way the conversation had occurred was kids who are not being stabilized in the ED. And it's really uncertain exactly what level of care they may need. And it could be that they could be stabilized in a subacute rather than in acute based setting. So here's the list and the target population and the way that it's been described here.
Yeah, no, I read the list. I just didn't understand. Are we talking about family crisis or child in crisis? Because if this is an unlocked facility, we're probably not talking about a child in crisis. We're talking about, again,
we are talking about a child that may not be completely stabilized, but it is unlocked. If you, I mean, if you're objecting to the level of care of subacute, there is good evidence for it and use around the country. And there are multiple models, and that was one of the things that we've done. In fact, again, I think we shared some of the best practice from the SAMHSA grant, from the SAMHSA documents early on. And there's clearly a level of care there. Are you objecting to Connecticut's PRTF also? Is Yale objecting to that also?
Yeah, in my question, I wasn't objecting to anything. I was trying to get a better understanding of who this is proposed to serve. And from what's laid out here, I'm still not fully understanding. Again, like I said, it's not anybody under 12. So it's younger adolescents, adolescent population. But is this, I'm thinking about what's going on in RED. So last week we had 3 kids stuck in our emergency department because they were basically dropped off there and whoever was responsible for them would not take them home. So there they sit. So this is more of a family crisis. This morning I was in a meeting where I'm told it's about 1/3 of our kids. It's a family crisis, not specifically the child in crisis. So if foster mom or guardian, grandmother, whoever brings a child to the ED and won't take them home, do they go to a crisis stabilization unit while the family works out their stuff, or do they still live in the ED?
The referral pathways that are described in here, I think both of those scenarios are possible. It could be kids who are stuck in an emergency department and need further stabilization or family stabilization to be discharged to a community level of care. But it also could be that crisis stabilization units for children with moderate level needs that don't require inpatient hospitalization bypass the emergency department altogether. And by providing another option, you may not see that child present to the emergency department to begin with because they'll have an additional option of a CSU available to them.
Thank you.
And I'd be very eager to hear other people's thoughts about, because I do think that target population question is really important. Being able to distinguish between what's appropriate for inpatient level of care, what's appropriate for urgent care crisis stabilization versus PRTF. I mean, those are some of the more challenging, and there's overlap in those things. Like there can be target populations that are appropriate for multiple levels of care. Obviously, it doesn't have to be that CSUs or urgent care meeting the needs of a very specific population and no other level of care meets those needs. But we do want to try to get the target population description as close as we possibly can.
Do you think? I should have raised my hand. Sorry.
Go ahead, Jason. And then if there's, think I heard somebody else chime in. So if you want to put your hand up, I'll go to you next. Go ahead, Jason.
Do you think that we could perhaps like bullet a line saying what a definition of subacute versus acute actually is? And maybe that's my own knowledge gap, but really defining what the difference is, because there's criteria, but many of these criteria I feel like are some of our inpatient criteria, high risk behaviors leading to self-harm, but could be avoided, like that kind of stuff. So what really is the difference? I have a very hard time just understanding the difference sometimes.
Yeah, and I think that my understanding, so one of the meetings that we participated in yesterday were folks around in those 3 states who actually are part of setting levels of care similar to what Beacon Health Options does here for us under the Connecticut Behavioral Health Partnership. And so we did look at the different levels of care, and we continue to unpack those different levels of care. But you all would probably know better, but maybe you only exclusively refer to inpatient and never refer to PRTF. But again, I wonder how you all are distinguishing between a subacute PRTF referral today and an inpatient bed today. Do you know how do you guys do that today, or do you not make referrals?
It's impossible to refer to a subacute PRTF today from the ED. It's absolutely impossible. At least it's unheard of, because
I don't think we really ever do that. Yeah.
I think that's more of a practice. We take kids at Eagle House from the emergency department, especially from CCMC, just because they're right up the street. But I think from my perspective, the difference between for a kid that is sort of ready for a subacute level of care is that there is an ability to be able to be in the community with intensive 24/7 supports, with a plan of being able to be transitioned back into the community at the home level. So that, it's not a locked facility, it's a very open area. And so the expectation is that the kids would be able to be maintained in a much more open environment and not require a locked facility in order to be stabilized or maintain stability.
Thank you.
It seems to me from a practical perspective, because we frequently get called about youngsters who have cycled, repeatedly through to the ED, maybe multiple admissions, have had lots and lots and lots of attempted in-home supports, that the decision or the kind of decision to refer a child to a PRTF often is made based on that, right? That this is a child who continues to cycle. The family isn't perhaps supported or stable enough to receive the child back with another round of whatever continued in-home services. And that there is a belief that it's going to take more than a couple of weeks to actually stabilize and get that child ready for a less restrictive environment, right? So I was thinking though that, so Beacon has, with the partners, Beacon has developed eligibility criteria for referral and acceptance into PRTF. And how does it match up to this, right? Because it sounds somewhat familiar, but did we do any kind of matching of that?
Yes, so we did that. Yeah, so that's
what I thought. Okay.
Yeah, we want to make sure that the 11, and again, maybe a lot of the docs on this meeting could speak to it, but my understanding of speaking to now what was 3 or 4 medical directors who are often in charge of the final decision-making of approvals for levels of care, at least in the Medicaid realm, is that there is certainly guidelines and there's got to be published and written, but that often final decisions are made during a conversation between the ED doc and the approving doc. Now, maybe that doesn't happen, but that was what I was led to understand, so that there's often a conversation or frequently conversation, and that there may be some nuances that are talked about that then they say, oh, this child might be able to do kind of a subacute, again, whether that's PRTF, which exists today, but we're just talking about adding a second model in Connecticut for a second. Again, we're just trying to grow out the level of care here, of which this was one of the suggested practices
sure.
that come with the Fed's
Sure.
suggestion.
And you know, the other thing that strikes me, and I have not been able to be on every single one of these meetings, but I think that that the whole issue around what happened with SFIT is still very unclear to people, right? And so we have heard that they were either underutilized or being utilized in a way that they weren't necessarily developed to be utilized, right? So do you think, I think maybe it would be helpful to have some discussion or some information shared around how the department came to the conclusion, or the department in concert with whoever else was involved in that decision, so that you know, because it seems that we keep cycling back to that, like, that is this, you know, kind of replacing SFIT? Why isn't this SFIT? And I don't know that people are really clear about what happened to SFIT.
Yes, and again, I think we've talked about it in this group. There's different levels of care, and that level of care that we're referring to is often referred to as short-term residential, or sometimes is referred to as crisis residential, or sometimes referred to as, well, the short-term residential. So then those pieces have been put forward also. So I didn't manage the SFIT. I did many years ago, part of the system. I managed the 2 Connecticut crisis stabilization bedded units that we had, and we had 2 that existed. And again, this is a part of the original blueprint of the Connecticut Kid Care Plan that goes back to 2002. And there was plans for 6 of those units, 2 of which were built. And then they eventually converted when we converted to the SFIT. And again, I was a little bit a part of that. So we had what was the crisis respite or short-term residential level of care, which is a different, separate, unique level from crisis stabilization. One is a subacute, the other is not. And then we eventually attempted to merge those. And I think part of the challenge with the SFIT was we were trying to do 2 different things under one roof. And we removed kind of the subacute criteria because you couldn't have mixed the populations. But historically, those 2 crisis stabilizations, Children's Center and the Greenhouse at Wheeler, did take a higher acuity rate child. That was for a period of time, but there were some reasons why that didn't succeed. There wasn't a full model implementation across the state. So it was hard for 2 programs to exist independent of others. And there were some pieces of that component that was a higher level of care and that we paid higher rates of reimbursement for, that we did not pay for the crisis residential or short-term residential. The biggest issue, from what I understand, that we had a vacancy rate of about 75% for the last number of years. And so when we made the decision to get rid of them, we had this huge outcry in response. But the reality was most of those beds were empty most of the time. And so the model was that we were paying for empty beds. So we were just trying to be a little bit more efficient use of taxpayer dollars and trying to make them work better. And so there's more than one way to do that. But the department made the decision to move in the direction it did. And then again, has since kind of pivoted. So that's a little bit of the background. I think I saw Lane and then I saw Tammy, but I think those hands went up and down. Is either you guys have questions or comments at this point?
I'm good. I'll defer to Tammy for right now.
Amy also said that her point was covered, so we'll go to Frank.
Okay.
Just, I put the level of care guidelines from Beacon in the chat, and it does feel like threading a needle to create subacute, 1 to 14-day programs. It's clear the PRTF is targeting 30 to 90-day length of stay for those who step down from inpatient, and targeting 15 to 30 for those who are coming from the ED. Again, what Lane says about what happens at Hartford that's terrific. I don't think we've ever, felt we had access to that, and that perhaps that's our issue for, not reaching out and educating more about that level of care. But it does feel like just threading the needle here with trying to differentiate between inpatient and then, subacute 1 to 14 versus subacute 15 to 30 days. And
So I guess we continue to hear the same perspective. I understand. Are you challenging that it exists or doesn't exist across the country? Number one. Number two is you can also make that argument about many different levels of care as you shift from one to another, that there are times when kids transition from one level or another, and there is, discussions that take place and say, oh, maybe the higher level when we're talking about 2 is better than this lower level, or 2 very similar services. So I'm wondering if we can move forward. We're hearing the objection loud and clear. But I think we're still trying to put forward a subacute model that's not foreign around the country. It might be, and there's some objection to it here. We've heard that, but I guess, is there specific parts of the model that people want to strengthen? And we've heard adding some clarification around target population, around level of care determination. And if there's other parts of it, we'll be happy to continue to entertain that.
Yeah, I just want to be clear. I'm not challenging that it does exist around the country. I know it does, and I spent times practicing in another state, and I know there are different models. But also there's a lot of differences in other states with regard to their entire continuum. And so I am struggling to understand how it will fit in our continuum, but we can move on. I don't want to hold it up anymore. I think the draft that you've come up with, reads very, very well. I'm just putting on my practical head and thinking, how will this actually work? But I don't want to hold the group up more. We can certainly move on.
And we'll, and just so everybody knows, it's not just, going into a void here. We're hearing what you're saying. I'm taking some notes. I'm sure Elise is taking some notes, and Tim as well. And if there are areas of the report where we can add a little bit more clarity, so just as an example, a brief summary of either target population or admission criteria for inpatient PRTF, and how that relates or doesn't relate to what's being proposed around CSU, maybe some good context to add to the report. And as I said earlier, this notwithstanding investments that need to be made in other parts of the system, and that's another area of the report where we can say that that if this were to be implemented, it could only be successful if there were other investments and other levels of care that accompanied this approach. So I just want to make sure that it's not falling on deaf ears, and we'll, in our next iteration, incorporate some of this input. And again, if at that point you continue to receive feedback from people about the next draft, turn it over to Carl.
Thank you, and good afternoon. And throughout this experience, I've been sort of curious about the what happens next, part of this proposition. And there's so much interest and so much activity in this area that I do think how we say what we say becomes as important as what we're saying. And so, what I've discerned throughout this experience with this particular work group is that, our charge was to essentially consider the viability, of an alternative approach. and we've identified two alternative approaches. And the notion was, to my mind, proposing consideration of that model for the state of Connecticut, not implementing, not funding, not working out the clinical aspects of it, and how to fit it into Connecticut. That seemed to be something for others to do. So when I see, a draft report that uses the phrase recommendations, for example, on the second page near the top, the work group recommends that Connecticut place CSUs within community-based organizations and with a requirement for strong community hospital partnerships. I think what we're hearing is conceptually worth exploring, but the devil is in the details. And I'm not sure I'm hearing this group recommend that action. And I'm not hearing from the sponsors necessarily that what we are going to tell the rest of the world, I presume that's DCF, which is the department that organized this work group as a result of the summit, and the Children's Behavioral Health Plan Implementation Advisory Board, which, by the way, is just that, an advisory board, has no authority beyond advising the department and working with the various agencies and stakeholders who participate in that group. And I suspect the group of agencies that are meeting now to talk about steps that can be taken to improve the system for all children. So I get worried that what appeared to be, in some respects, a bit of an academic exercise to define the parameters of a potential model for Connecticut, but stop short at figuring out things like how to fit it into the existing continuum of care, how to pay for it, how to staff it, where it will be. All of those things seem to be work that's a pretty fair distance away from what we're doing here. So I'm not feeling 100% comfortable making recommendations unless they're worded very carefully. And frankly, the recommendation that I'd be most comfortable with is, we've identified this as a model. It is worthy of consideration. Here are some of the opportunities and challenges associated with this model that we've been able to identify for the state of Connecticut. And then I guess we end and some other group takes it from there, which personally is less than satisfactory, for me as a next step.
Carl,
so thanks for listening to my perspective. And I'm going to stop talking now and let Tim reply.
Yeah, so I'm again apologize if I thought we made it abundantly clear in the first group and we said out loud, if Connecticut was to implement these two levels of care, how would we do it? And I just want to remind that the decision was put forward in the original plan itself, and then that got pulled out of the original plan and was highlighted as one of the 4 areas of focus. That's how this work group got established, was that there was a call for the original plan in 2014 to look at developing alternatives to the emergency department situations around the country. But in Connecticut, we called for that in 2014. And accompanying that was a crisis stabilization. And in fact, again, we put that forward as coming along with the BH urgent care setting. So again, it sounds like a little bit of splitting hairs, but we were pretty clear that if we were to put this forward in Connecticut, what would it look like? Tammy?
So in response, let me just retort quickly, and apologies, Tammy. So if that's the case, so we're getting closer to the real world, then this report we make needs to acknowledge, the practical challenges associated with how does this model fit into the existing continuum of care? How do you sustain it? And frankly, how do you pay for it? In my opinion.
Our group was not asked to figure out how to pay for it and sustain it. So that's not what we would ask to do. Tammy?
I don't know to what extent this is helpful at all, but it is a process thought that came to mind. And since Jeff is taking notes that are not necessarily directly related to something that we might see in the kind of the model considerations and recommendations. I just wanted to raise it. I mean, I do think that the point about the, kind of what about SFIT question is a really important one. Like, what do we know about what worked and what didn't work? The program is clearly still being used, at least to some level. What gap is created when it goes away? I know that there are lots of ways that things kind of happen in terms of state procurement and support. And I know in the past, DCF has used a kind of a redesign mechanism to bring together providers who are working in that space and perhaps other stakeholders to take an existing service type like an SFIT and convert it to something new, a new model with a new clinical basis or a new intended outcome or whatever, but that these recommendations could actually kind of feed very well into that kind of process in terms of process, thinking about it as an SFIT redesign rather than as a brand new thing. Anyway, just my thought.
Thank you. And again, just as a reminder that we did have 2 of these subacute models in Connecticut for a period of time. And again, we were not satisfied with the way they were operating many years ago. But the other part of it was that these 2 levels of care, and I don't know, Jeff, if it would make sense at this point to potentially, one of the things we thought we would have prepared in case it had an opportunity, but one of the things that we've not done well in Connecticut is to talk about how the whole system is integrated and works together versus building things separately. And one of the areas of crisis stabilization is direct admit from mobile crisis, so that you could avoid the ED altogether also is another avenue in. And one of the best practices would be to look at your full continuum of crisis intervention. And so we started to play with a visual for that. And we were thinking that might be something that we want to submit, and we shared it yesterday with the Children's Implementation Advisory Board. So this is that, and essentially we're just trying to send the message here. And we've went through 3 or 4 different iterations of different visuals, but really the key is to be sure that we're talking about different ways and avenues that kids in crisis could be stabilized. And again, you have ED, you have an alternative setting to the ED, whatever you end up calling that. You have mobile crisis, and for all intents and purposes, mobile crisis, and again, if referring back to the SAMHSA document, is that mobile crisis becomes integral as the glue, so that the more folks that you can get assessed through mobile crisis, the better your system's going to be. Some kids obviously need to go straight to the ED or an alternative setting, but the more you're able to utilize mobile crisis, the better. And then there's the kind of the community the CCBHC system, which are federally funded, and we put them on here because they also have a 24-hour crisis response requirement in that model. And then enhanced care clinics, being able to be responsive to kids walking in the door for kind of a crisis assessment and kind of a link to care. And then the alternative to the ED is kind of listed here. So again, we're still playing with the best way that the visual would play out. And then community-based care, intermediate levels of care, and acute care under the acute, the subacute, and again, the crisis stabilization. And then on the bottom, we were trying to acknowledge the enhancements that the whole system needs to be made to work together. SAMHSA again put forth a series of visuals like this, and most of theirs promulgated kind of puts and highlights mobile crisis in the center, if you will, is kind of like they actually use the term air traffic control, so that they are able to see the whole system and then have direct access to either admission or appointment scheduling in whatever level of care is necessary, or at least have opportunities to make recommendations for that and or referrals for. So again, I think the point that I'm making here as in response is that we're trying to do both, make recommendations for the implementation if Connecticut was to choose to implement these two levels of care. What it would look like in Connecticut as a best practice, and then how does it fit into the whole overall system. And so again, that was where we were coming from, in that we need to be sure that we see the system working together in partnership with each other and not in isolation. So I didn't know if that kind of takes us away from the crisis stabilization design, and we do need to and want to finish that document. And we are wrapping up our recommendations. So part of this is kind of trying to deliver what we set out to do from the very beginning. And so if there's responses to that goal, if you will, of what we articulated from the beginning, again, certainly people can share those with us. But so that would be my response there.
Tim, I don't know if you want to take the time. It's 1:46. We had 15 minutes of next steps, identifying next steps that we had on the agenda. You may want to just talk about what the plan is for wrapping up the activities of this work group. That includes both the urgent care and the crisis stabilization conversations, including the comments that have been made today.
Right.
So we can either pivot to I can actually share the slide on work group recommendations at this point, or you can spend some time identifying next steps if you want to go an alternative route.
Well, I think I started off with the next steps. For this work group, we're finalizing both the written form of these two levels of care, for lack of a better term. Some people suggest that the alternative to the ED is not quote unquote a level of care, but it's a new service. So the 23-hour document and the document for the crisis stabilization unit. And those two things we'll be putting forth in the context of some of the other system recommendations that this group has discussed and made recommendations for. So I think, again, you all have seen the draft on the urgent care thing. And I think you can see that we put those in the context of that full recommendation, that full document. So that would then be the concrete deliverable that this group worked on. This work group also pivoted and developed the short-term recommendations. We finalized that document and those were distributed. The data integration report and the alternative payment mechanism report, those two are also being finalized. And as a package, this was the week we were going to deliver them to the leadership. And so yesterday at the Children's Implementation Plan Advisory Board, we gave a sneak peek of all those recommendations. And so those will be coming out in a full package and then be delivered. And at that meeting, there was conversation about what will happen next. There's a few people on this group that were on the data integration, and there was a desire to help us develop implementation plan for interaction with the P20 WIN project. So there's probably going to be another 4 or 6 weeks of a different group using the same group members, inviting them to participate for another 4 to 6 months to finalize that project. But then the remaining 3 groups, including the short-term group, the question was, what about accountability? What about updates? What are we doing? So we thought that it would make sense to have a follow-up routine meeting schedule to check in on a variety of the recommendations on a routine basis. But as was discussed yesterday, and as we mentioned briefly before, the big challenge is, well, whom is the decision maker? And I am not the person to make those decisions, but I am frequently consulted on. And so I give my opinions when asked. But bottom line is, historically, you're talking about two parts of the government. You're talking about the executive branch under the governor, which the commissioner in my department falls under, the commissioners and and then you're talking about the legislative branch. And I think that's essentially what's beginning to happen now, is a dialogue in different forums about what that is happen, what will happen and which projects will be funded and which won't be. There is some amount of money, is the way I understand it, that's still uncommitted, and that somebody is going to be making some decisions about prioritizing that. And the children's behavioral health system is not alone in it. The adult system is also gearing up for some recommendations, is the way I understand it. So overall, those are decisions that are often made in different avenues. And I think that it's hard for us in a work group like this, because we always want to know what the next steps are. So I think as best we can, we'll stay connected in a meeting of some kind, and we'll put it out to all the work groups to say, here's the ongoing update, whether it will be monthly or every other month. I don't know what the cadence would be. I would assume we probably want monthly. And then we'll go from there. But as I said, also, what just as a way to go backwards, remember that what turned up quite a bit, because again, this work was in progress before the pandemic, was that the pandemic kicked it up quite a bit. And then also the ARPA money that became available, because the task of this group before the pandemic, we had no funding source. So our challenge was going to be, how do we put forward these recommendations and then figure out how it would be funded? And so the ARPA money is actually afforded Connecticut an opportunity that didn't exist before the pandemic. So I'll pause there and see if there's any response or questions, or Jeff, if you think I need to clarify anything.
I think we're nothing further to add. I'll open it up for any other questions or about next steps.
Yes, thank you, Carl. So one of the challenges that I had in, so Carl just put in the chat, if anybody didn't see that, ARPA's short-term expiring sunsetting money, if you will, and there are a variety of pots. And one of my responsibilities here at DCF, I was responsible for overseeing the creation of projects on the one-time COVID supplemental dollars under the mental health block grant. There was a second pot of money called the mental health block grants, ARPA supplemental. Those each, one was 2.5 million, one was 4.2 million. And quite frankly, the challenge of those projects was we were asked to develop projects that were consistent with your in-state children's mental health plan, yet at the same time to develop projects that would try to be responsive to the pandemic and meet needs. And oh, by the way, these are all expiring or sunsetting dollars. So if you are going to build anything that's going to be sustained beyond the timeframes, you need to figure out how to fund that. And our matching was to be receiving guidance from OPM to say, if you want something to be sustained, you need to put together a plan about how you do that. So in my area, we developed a bunch of projects that would last 1, 2, 3, and a few that would be 4 years and would all sunset. And there were a handful of projects that we had put forth that would be sustained. And we made a decision that we would realign our mental health block grant dollars to support those going forward. And so that's what I did under those. Some of the ones that you all saw publicly under the governor's position, the governor's release of the expenditures were to be sustained under the Medicaid reimbursement rate structured system. So those were the two primary ways. But in the end, I think there's probably going to be no way to avoid that. Some amount of this will eventually end up on the state general fund, and which is why OPM, I think, has been so closely tuned into all of the activities occurring. So that's would be my response in summary back to you, Carl. And so appreciate that. Any other questions or comments? So the next steps, concretely, you'll get another draft, or the final draft. Hopefully, we'll ask you with some closing. We'll ask you to speak to the document, and if you guys have responses beyond the goals of the group, feel free to send those. Before the meeting, I think Yale sent me a note saying that they would like to put something in writing for us. Be happy to receive that. if others feel a need to do that, that is kind of a little bit beyond the goals of the group, feel free to do that, particularly around prioritization of spending around that point. I think that the main point that we want to reiterate that we heard that Yale in particular would feel like the money, any money spent to create a second subacute in the state of Connecticut would be better invested in enhancing other programs. So I just want to be sure that we summarize that correctly. And that's a valid, important point, but it is a little bit beyond the purview of this group. So our task was originally, if this was going to be implemented, what would it look like? So but appreciate those comments. Yep, go ahead, Frank.
Can I ask a process question?
Sure.
Earlier, you said it wasn't the purview of this group to determine ongoing, funding and sustainability, if I heard you correct, for a crisis stabilization unit model. It was just to, help to decide what it would look like. If it wasn't the purview of this group to look at ongoing funding and sustainability, then whose decision was that? Who made that decision?
I'm sorry, who made which decision?
Decision that it would be beyond the purview of this group to consider.
Yeah,
funding.
so again, the genesis of this group existed before ARPA dollars came into our lives. So it actually, our task first was to develop the model, and the second, we were going to have to go out and figure out how it was going to be funded. And so we actually kind of won the jackpot, if you will, when ARPA dollars came in and kind of made it possible for this to probably happen in a much more quick fashion, although my administration made the commitment. And Carl, you can recall that the tri-chairs, they brought in and said, hey, we should have paid more attention to the plan when we first came into our appointments, but we want to make sure that we move forward on it now, and that we kind of maybe didn't pay as close attention to it as we should have early on. So, again, we go back to 2014 that these recommendations have been around, and I don't have to tell the EDs that the surge that has occurred over the last number of years in the spring and in the fall, the times when it hits peak, isn't new. And so the recommendation for alternatives to emergency departments has been around for some time. And our administration made a commitment to say, let's figure out how to do it. And before that, we had the summit with the 12 commissioners, and we had a number of meetings internally with the 12 commissioners to discuss getting support and alignment to move forward with some of the big potential costs that would be associated with it.
I hope, with all due respect, I hope you understand that why I'm still struggling with separating out those things, because in the role Jason and I have at Yale New Haven, we couldn't possibly think about a program without figuring out how we were going to fund it. I mean, the two are it's just integrally related.
Yeah, don't let me mislead you either. A decision, once a decision would be made to fund either one of these levels of care, believe me, there would have to be a support, both administratively support as well as OPM for sustainability. An urgent care or crisis stabilization would not be built on sunsetting dollars. And so there has to be a commitment to that. So, but what I was saying generically is that's beyond my personal level and what I was asked in terms of facilitating this group. And I just want to also acknowledge there are really two large stakeholder groups here. There's the community-based provider group, and there's the hospital and the hospital-based and the hospital association. And we heard quite a bit from the hospitals because of the ED crisis, but there are a lot of feedback from a community-based perspective also, and the two positions don't always align. Frequently they do, but they don't always align. So I just want to also acknowledge that too. We're at time. 1 minute left. Anybody want to jump in? All right. Again, thank you all. And please hear us that we also understand that differences of opinion doesn't wash away our appreciation for all of the work that you all have brought in, all your expertise. We greatly appreciate it. We have a great deal of respect. And as I said many times, I think we all have to do as best we can to do better, working together and in collaboration with one another. So do appreciate it all. So thank you all, and stay tuned for what next, but we appreciate your 6-month commitment to this group, and we'll we'll get the draft out to you and put in final drafts as soon as we close that period out moving forward. So thank you all.
Thanks.
Have a
everybody.
great day.
Bye.